Totalement. Greetings, Afton. Greetings, Afton. Hi, Nargiza. Hello,
Hi,
can you hear
John.
me?
Yes, I can hear you. Hello, John. Good morning.
You're very subdued.
How are you?
Where are the white gloves?
No gloves today.
Dr.
Um,
Gabullo! Dr. Gabullo is a welcome guest
yeah.
from, do you know Dr. Gabullo? From Africa, from Congo?
Hello, Dr. Kabula.
He may have stepped away.
Hello, everyone.
Hello,
Welcome,
everyone.
welcome,
Thank you
Dr.
so much.
Gabullo.
Yes, thank you, everyone.
Thank you. We are happy that you are joining our webinar today.
Yeah,
So,
thank you so much. Nice to be here.
Haven't seen you for a while, Dr. Gabullo.
Yeah, of course, I was a little busy, but these days I'm there. You will be seeing me. And Dr. Bennett, soon you will get your official invitation for the Cancer Congress in November in Kinshasa.
Oh, okay, that would be great.
wow, John,
Yes.
congratulations.
Thank you.
Yes. We are inviting him in Kinshasa for the Cancer Congress, the Continental
Yes,
Association of Neurological Societies. It will be held in Kinshasa and Brazzaville, the two closest capital cities in the world. So Congo Kinshasa and Congo Brazzaville.
That's
yes,
He's
right.
yes.
our guest of honor.
Oh, good.
Great.
You know, there
Yes.
are, I don't know if you know the geography, Nargisa, but there are two capital cities right
I
across
know,
the
I
Yes.
know,
river. You know that?
I know. Of course, I know. I know geography a little bit, John.
Oh my, well, that's not, hey, wait a minute. That's kind of geography unusual. Most people would
Mhm.
not have any idea what I'm talking about.
Mm.
That and the Congo, I didn't know certainly. But
Mhm.
and how many neurosurgeons in the Democratic Congo? Like 10, right?
19 for more than 95 million population.
Yeah, can you imagine that?
And
95
we are only
million?
based in 95
Okay,
million, more than 95 million population.
on more than
19
95,
neurosurgeons
90,
only.
90
One
neurosurgeons. Oh my
nine.
God.
One
Can you
nine,
Mm-hmm.
yes.
imagine? Can you imagine that?
Yes. So you are
Yeah.
doing a great job covering
Yeah,
such a
of
big
course.
population.
Plus, he has
True.
time for
Always
education
busy.
too. You know, we're changing things, Dr. Kabulo. We're trying to change things to try to have medical companies sponsor the conferences.
Yes, we are trying to get
Yeah, that's
financial support.
that's very serious. You know, I really got to get serious about this. If I want this project to develop, especially with so much coming up, going on as far as education, augmented reality, all these other things are going to get big. They're not just little toys.
All right.
And certainly from my point of view of products, I mean, actually, the interface for advertising improved a lot, and most advertisers don't know. But I won't talk about that. That's not really the topic here.
Mhm. Okay, let me just check who has joined.
Okay.
Okay, Anton, make a panelist.
Oh, I gotta make a co-host.
Yeah, could you make me co-host, please?
Hi, Joe. Hi, Nargiza.
Welcome.
Hello,
Did you hear me?
how are you?
Okay. So link is works.
Mm-hmm. Great.
Host.
No,
Anton, you're one of the
thank you.
speakers, right?
Thank you, John. Mhm.
Dr. Gabula, are you there?
Not yet, Alexander.
Yes, Dr. Bennett.
I'd like you to meet Anton Ivanov. Anton, didn't you speak a few weeks ago? Are you there, Anton?
Okay, no problem. Which date?
Anton, did you,
Oh.
you're presenting today, right?
Yeah, right.
Yeah, I'd like you to meet Dr. Kubulo from the Democratic Republic of the
Of
Congo.
Congo.
Hello, Anton.
Hi.
How are you?
Okay,
I'm
now
fine.
Giza.
Anton,
Okay,
Anton is our second-year resident of
Oh, okay.
Federal Neurosurgical Center in Russia, in Siberia. So he's doing quite good. So he's giving a
Oh,
lot of
okay.
opportunities as a young neurosurgeon. So, and
Yeah.
myself, Dr. Nargiza Saatova, I'm from Uzbekistan. So
Okay.
hosting these webinars.
Okay, I'm gonna test
Okay,
Anton.
nice to meet you.
I'm gonna test
Nice to
Anton.
meet you too.
Anton, what countries in Africa have capitals that are right across the river from each other? And watch this now, Giza, he won't know. Do you know,
What
Anton?
countries does Africa have then? What is the
Yeah,
next part?
capitals
Uh-huh.
across the river from each other that are very close to each other. It's the Congo.
Congo. Okay.
Oh,
You
okay.
know it. You know it now, Giza. You told me.
Yes, yes. Yes. Let us see. We are waiting for attendees. Um,
Yeah, Mario? Right. There's James. Let's see here. Hello, James.
Hi, good morning.
How you doing?
Good, good. How are you?
New
Good morning,
Jersey
good
and
afternoon, everyone.
New Jersey and Russia.
Hello.
Hello,
Hello.
Professor Jamil. Hello, Professor James, everyone. So in few minutes we will start. So we are waiting for Dr. Kazadi to join, and all speakers are here.
Is the first speaker here?
Dr. Aldo. Yeah, first speaker will be Dr. Jamil Rezaev.
Okay, so we can start, right? And we'll await following speakers.
Good morning, Nargiza. Good morning, gentlemen.
Good morning.
Good morning. Can somebody hear me? I cannot show any video of myself, which is very bad.
Okay, let me
Okay.
make sure you're in.
May I ask Dr. Bennett and Dr. Leo, what time is it now in New Jersey and in Florida?
5 o'clock.
5 a.m.
5 p.m.
AM.
Good start for Sunday.
5
Good start
5
for
a.m.
Sunday.
AM.
AM, early morning.
Yeah, I see. Good start for Sunday.
Good for
Good morning, everybody. Good morning, everybody. I'm sorry I cannot
Good
see
morning, Mario.
activate
morning,
my
Mario.
video
Mario.
here.
Aldo, you having a hard time sharing? You can't.
Yes, actually, can you hear me?
We
Yeah,
can't hear you,
can you
but
try
we
to
can't
share?
see
You want
you.
to try to share real quick?
I don't know. I'm trying to not hide myself, but I'm hiding it, unfortunately. No.
Or do you have a screen share option on your screen on the bottom?
Screen share.
It says, yeah, open that up. Open that up right now. Open it up now.
Okay. Sure.
Yeah, so you got it. Okay.
Are you sure I'm there? So my
Yeah,
presentation can be there.
No, your camera, yeah, you can put your presentation just where you went there.
Yeah.
So you do have a screen share option.
Yeah. Can you see something?
Yes, we can.
Okay,
Yes, we
good.
can.
But you can't see me.
No, I can't see you, but I can see the, you've
But
never done a Zoom
I am better looking usually.
Oh, okay.
Я
Окей.
действительно красивее, и товарищ Жамил, который меня видит, может быть свидетелем, правда?
Yeah.
Great.
Да.
Really.
Okay, I'm gonna take you off the screen share.
I look in that picture like Mr. What's his name, who used to work occasionally with us at the EMC. What's his name? Another French lover of Russia called, I'm missing his name.
Okay,
Somebody
ready to
from
start?
France.
Ready to start, Nagisa?
Yeah, I'm actually surprised that in this picture I'm looking pretty much like him, and I wanted to commit suicide, but I won't do it.
Oh,
Я не буду себя
Wait.
убить, так я был похож
No.
на этого товарища.
Wait, after, okay, we're gonna start now, okay? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett broadcasting from Miami Beach. It's just as sunny as here, but it's 5 a.m. in the morning. We have another Russian neurosurgery grand rounds. And today we have four talks, I believe, and Nargiza Sartova, Uzbek neurosurgical resident currently. It's hard to keep track of her. I think she's in Turkey right now, but she's going to moderate the proceedings. Welcome, Nargiza.
Hello, everyone. Thank you, John. It's a great pleasure again to host our 12 webinars, Russian Neurosurgery Grant Rounds, and I think we are going quite well. And today we have our skull-based session. We will be talking about approaches. And let me introduce my co-host, my good friend and colleague, Anton Ivanov. He's a resident of Federal Neurosurgical Center in Novosibirsk, Siberia. Please, Anton.
Hi, everyone. So let me the first speaker. So
no, Anton, please introduce Dr. Mario, our moderator. So,
Hello, everybody. It's Mario Gano here.
Dr. Mario Ganao, consultant
consultant
neurosurgeon
of
and
the
spinal surgeon.
I'm going to moderate this session. And so we will have the talks from the various speakers, and then I will moderate the Q&A session. Thank you very much, Nargisa. The mic is back to you. Thanks.
Thank you. So, our first speaker, Anton, is a little bit lost so far. So let me introduce our first speaker, Dr. Jamil Rezaev, MD, PhD, neurosurgeon, chief of the Neurosurgical Federal Center in Novosibirsk. And today, Dr. Jamil Rezaev will be talking about lateral supraorbital approach. Sir, the stage is yours. Thank you. We can see your screen.
You can see my screen?
Yes, we can see your screen and we can hear you.
Okay. I thank Dr. Nargiza Saatova and Dr. Anton Ivanov for the opportunity to share my humble experience in brain surgery at this Zoom meeting. And also, I'm glad to greet my co-speakers, distinguished professors, Professor Spallone, Professor Liu, Professor Calango. And again, I'm honored to attend this webinar. My topic is not dedicated to rocket science in our field, in neurosurgery. We can see some examples of extraordinary neurosurgery for extremely complex and challenge cases. But there are some fundamentals and basics which every brain neurosurgeon must know. So today I'll talk about a working horse of microneurosurgery, about lateral supraorbital approach. I might be telling you about well-known and maybe even obvious things. And also I know that Professor Calango will deliver his talk on approximately the same topic, so I will try to be brief. There are different approaches to the anterior zone of skull base. I mean just transcranial approaches, except different transnasal routes, transfacial split approach, or transfacial degloving approach. I'm talking just about transcranial approaches. So these transcranial routes can be divided into two big groups, anterior and lateral anterior. Professor Yazargil, who had described pterional approach, started a new era of microneurosurgery, and he created so-called pterional point of view on neurosurgery. And lateral supraorbital approach is a smaller variant of pterional approach, which allows us to decrease unwanted, unwilling injury. Here, I'd like to point out the advantages this approach. Through small craniotomy, a surgeon is able to achieve good brain relaxation by opening arachnoid cisterns. This approach allows us to perform broad observation, broad exposure of anterior fossa and sellar region. The patient is positioned supine with shoulders and head elevated above the cardiac level, and the head is fixed to the frame with pins and rotated from 15 to 30 degrees towards the opposite side. Tilt laterally and extended for more brain retraction. The exact position of the head depends on the localization of tumor or arterial aneurysm being approached and is adjusted on case-by-case basis. I think that the choice of technique of skin incision is only a surgeon's preference. I do both types of incision, conventional, a little behind the hairline, and the eyebrow incision. But my rule is simple. Choice of skin incision depends on size of eyebrow. If the eyebrow is small, it's better not to make incision on the face. I routinely use skin infiltration by solution of local anesthetic and epinephrine. I prefer to use the Mayfield head frame with Dora-Luna retractor system, but using 4-point fixation of Sugita frame and using automatic retractors are acceptable too. Sugita frame allows us to rotate the head during injury. And we can obtain satisfactory cosmetic result in both type of skin incision, in eyebrow skin incision and hairline skin incision. And two short intra-op video. And please note that the bony edge drilling off makes floor of anterior here, of anterior fossa more flat, and we don't have to use the retractors. The dura opens parallel to lower edge of bone window, and you can see that there is quite a lot of space here. You can immediately open the CSF space here. And I almost never use brain retractors, but the size of bone window, it allows to do it. In addition, I can say that you don't need to open Sylvian Fisher White, but you can do it in any cases via this approach. This is our material for 10 years, almost 450 tumors cases, had underwent surgery via lateral supraorbital approach. And the cohort of tumors are divided like this. The first three leaders, the olfactory groove meningiomes, tuberculum meningiomes, and anterior clinoid process meningiomes. And the number of other tumors is less. And very briefly about mixed pathology, we had very rare tumor such as olfactory schwannoma. We had in this cohort one chiasm glioma, 2 cases of cavernous sinus meningioma, and others. This is one of clinical cases. These pre-op films. You can see tuberculum meningioma, and this post-op film. I'm sorry for not translating into English, but I'll explain to you. Also, you yourself see and understand everything perfectly, all structures. This is ipsilateral optic nerve, ipsilateral third nerve, this tuberculum, contralateral carotid, and contralateral optic nerve. And this ipsilateral carotid and ipsilateral from left side optic nerve and pituitary stalk. And this post-op images. And one more cases, this tuberculum meningioma, meningioma, right side lateral supraorbital approach. A very interesting question. What to do in cases where there is no lateralization of tumor growth? For example, the tumor is located in the middle point or almost middle point without lateralization. Which side should you choose to approach? But I stick in my practice to very simple rule. If there are no visual disturbances, then I prefer to operate from convenient side. Most of us are right-handed surgeons, and so it's more convenient to operate on the right. Accordingly, it will be more convenient for a left-handed surgeon to operate on the left. But this is all obvious. But what to do in cases of visual disturbances? I prefer to perform approach from unaffected, so-called healthy eye, healthy optic nerve. Because contralaterally, obliquely, it will be easier to manipulate the ill nerve and dissect it from all sides, especially when the tumor is located under the nerve or behind the nerve. I'll a little bit speed up my video. And this one more cases of meningioma of anterior clinoid process. It's not huge meningioma, not huge size, but not small size. This pre-op films and post-op CT reconstruction of right size lateral supraorbital approach. You can see here ipsilateral optic nerve and tumor. And this opposite side, contralateral carotid and contralateral third nerve. Here, ipsilateral carotid and ipsilateral anterior cerebellar artery. And post-op images. In this slide, you can see that the size of the tumor does not matter. Through this approach, we can remove even very large and huge tumors. We can work on the opposite side. You can cut and dissect falx. Falx is here. We can cut and dissect falx, drill an anterior skull base. And here, post-op films. And what about aneurysms? This is our material for 10 years, almost 1950 cases. This is total number of clipping. And of this number of aneurysms, we operated on via lateral supraorbital approach almost each 10th patients in 9% of all numbers of patients. Almost every 10th aneurysms in our clinic we operated through lateral supraorbital approach, and this is a distribution of location of aneurysms in this almost 200 cases. Most part are ACOM aneurysms and also carotid aneurysms and middle cerebral artery aneurysms. But I should also add that not almost all our aneurysm clipping cases were operated on in the cold period, that is not after the rupture immediately. This is peculiarity of our hospital. We mainly collect patients for elective cases. And one more short video. You can confidently manipulate the vessels of anterior circulation. You can use drill. You can use temporary clipping, and in general saying, you can use all tools of neurosurgical armamentarium of neurovascular neurosurgery. But I emphasize one more, that we are talking about surgery of aneurysms in the cold period, not in acute period. And the most interesting, what about complications? This is top 3 in complications: opening frontal sinus, hematoma, this is disaster, and leakage. If the sinus defect is small, and what is to be done in case of you get complication? If the sinus defect is small, you can get by this surgical box, but most often this is not enough, because if you damage the mucosa, the box will simply fall into the sinus, especially if it is a large one. So I prefer to use outer tissues, mainly harvest-free fat grafts. Even from a very skinny patient, a little piece of fat graft can be harvested, can be taken from the abdomen, from the paraumbilical area. And what about CSF leak? I believe that once a leak has occurred, the vast majority of cases require the operation. You should not rely on external lumbar drainage. How to say, the importance of lumbar drainage alone should not be overestimated. But what about glue? Glue is not bad issue, but we don't need rely on only glue. And one sample of disaster complication, you can see pre-op, this big olfactory groove meningioma. Not huge, but not small, of course. And after 12 hours, we got worse of consciousness, and we performed CT, and the patient underwent the reduced surgery with not bad result. And very interesting sample, retained catanoid. You can see from left side of my slide the X-ray positive string of catanoid. We performed, we left this catanoid and we closed wound. And after CT control, we got this picture. And patient was underwent reduced surgery, and we removed it. Interesting case of complication, I think. Okay, this is a short summary about this approach. This simple, fast, and convenient approach. We can get wide exposure area. This quite a cosmetic satisfactor. We can do wide arachnoid dissection. We can get brain relaxation, and in most of cases we can have intact sense of smell. But what about disadvantages? The bad exposure of retochiasmatic structures, anatomical structures, retochiasmatic area, and bad exposure of extracranial area, I mean sinuses, ethmoidal and sphenoid sinuses. And I want to say again that this approach should be in the armamentarium of any brain neurosurgeon. I don't call for simplifying our specialty and asserting that all problems in neurosurgery can be solved through 2 or 3 convenient and simple approaches. For example, pterional and the retrosigmoid ones. No, complex skull-based approaches should be known and should be applied. And today's following speakers will tell us about them. And my time is running out, and I thank you very much for listening to me.
Thank you, Jamilafitis, for the excellent report. Does anyone have any question for Dr. Jamil?
Yes, Professor, thank you for giving us this nice lecture. I have a question in regards to your decision-making on approach for tubercular meningioma. I believe you said that you prefer to go contralateral to the more severely affected nerve because it's easier to decompress from the opposite side. I believe you said that, and I agree with that. How do you decide if the tumor is symmetric and both eyes are equally affected? How do you decide which side to approach from?
From right side, because I'm a right-handed surgeon. More convenient for all members of team, for scrub nurse, for surgeon, for anesthesiologist. In cases of too ill optic nerves, I prefer right side. But sometimes it depends on size of frontal sinus too. If frontal sinus is bigger from right side, I will prefer left side to avoid the open of frontal sinus. I hate to open frontal sinus because this is source of many problems. This depends on not only an affected optic nerve, and depends on size of frontal sinus.
Okay, thanks. Does anyone have any other questions or comments? Okay, thanks, Dr. Jamil.
One second, can I ask something?
Oh, okay.
Yes.
I wanted to
Yes,
check
Dr. Mario.
with Professor, what is the rate of surgical site infection for this supraorbital approach?
The question is about some problems with infection, yeah?
Yes, surgical site infection, either superficial or deep.
We don't have wound infection, but of course we had meningitis, especially in cases of CSF leak. Yeah. I have shown you just the top 3 of our complications, but of course we have meningitis too, of course.
And may I ask, it's usually a bacterial meningitis, right? It's secondary to the CSF leak. You do not see sterile meningitis, chemical meningitis. Thank you so very much, Prof. Great talk. Thank you so much.
Thank you. Then we move on to the next report. Let me introduce the next speaker, James Liu, Director of Skull-Based Pituitary Surgery, Copperman-Barnabas Medical Center, Barnabas Health, Livingston, New Jersey. Dr. James Liu will talk about lateral approach for craniovertebral junction lesions.
Okay, can you see my screen?
Yes, we can see your screen.
Okay, terrific.
Thank you.
Well, thank you, Dr. Satova. Thank you for the kind invitation to speak in the Russian Neurosurgery Grand Rounds. I'm going to talk a little bit about a different area of the skull base, largely the foramen magnum and craniovertebral junction. And this is the approach that has been the workhorse for me, the far lateral approach with the different variations. Just to give you an overview, this approach provides a nice lateral trajectory to the anterior foramen magnum. So you can come in front of the brainstem towards the lower clivus and upper cervical regions. And there are different variations that we can use, largely to reduce the bone, namely the occipital condyle or jugular tubercle, to get in front of the brainstem. Certainly, a large tumor can create the corridor for you, and you don't necessarily need to be drilling those bones. So you have to tailor your approach to the particular pathology. Just a little brief historical background. This approach was initially described by Wolfgang Seeger and popularized by Bertalanffy and Harros and others. And the nomenclature can be quite confusing, and I think for young trainees, and there's different names and variations in the literature. I like to simplify it as the far lateral approach and break down the components for you so you understand the basic nuts and bolts of what is generally required for this approach. So in general, it's a lateral suboccipital craniotomy or craniectomy that is behind the sigmoid sinus, and it extends down to the foramen magnum. So it's very important you unroof the foramen magnum from the back of the condyle towards the midline keel. And in general, most cases, it's important to remove the hemilaminectomy of C1 arch, and very important to protect the vertebral artery. So this is your basic nuts and bolts, and this is what gets you to the foramen magnum and craniovertebral junction. And if needed, I think it's important to reduce the bone in this corner here. And this reduction of this bone is not necessarily drilling the condyle, but it's actually drilling the infrajugular jugular tubercle. And this area of bone is what blocks your line of sight. So as you drill this bone, just follow the dural tube. You don't need to drill this part of the condyle. Drill the bone that's close to the dural tube that is going to block your line of sight. The indications for this approach are the following. The workhorse is really foramen magnum meningiomas in the craniovertebral junction, but you can also get other intradural pathologies such as schwannomas and VA pica VBJ aneurysms and cavernomas of the brainstem and spinal cord, but also extradural lesions like chordomas and chondrosarcomas. So here's an example. This is a foramen magnum meningioma. You can see it's encasing the vertebral artery here. This is one of the workhorses. This is a pica aneurysm that's well suited for this approach. And of course, this is a cavernoma that's here right at the cervical medullary junction in the anterior anterolateral projection. So this approach gets you right to the surface of this cavernoma. Some anatomical considerations. These are from Professor Roten. Remember that the condyle can be at roughly 10 or 2 o'clock with some variations, and the course of the hypoglossal canal is going anterolaterally. And it's this angle that we are trying to get in front of the foramen magnum. So it's important to drill off all of the bone of the foramen magnum. And in some cases, you may need to reduce the medial 1/3 of the condyle. This is the hypoglossal canal looking from above, and the jugular tubercle is this bone here. So as we come lateral, oftentimes this bone reduction of the jugular tubercle I find actually more useful than reducing the occipital condyle. So different variations. We like to break down the access to the foramen magnum either through a posterolateral approach. This is the traditional intradural approach to foramen magnum meningiomas. And then the anterolateral approach, which I'll show you later on, is mostly for jugular foramen tumors such as paragangliomas and some chordomas, as popularized by Bernard Georges. So this is the posterolateral variant. I like to position the patient in a lateral park bench position, the head slightly turned down, vertex looking toward the floor. Very important to open up this space between the shoulder and the head. There's many variations of the incisions you can use. This is a classic hockey stick incision, or you could use a linear incision. I prefer to use a C-shaped incision. and then curved slightly downwards towards C1 and C2. This is the mastoid tip. This is the C1 tubercle. The muscle layers, there are different muscle layers that you see here in 3 layers, the classic 3 layers, where you have the sternomastoid as the outer layer, and then the semispinalis splenius capitis layer as the second layer, and of course, the deeper layer is the layers of the suboccipital triangle, which are the oblique, superior and inferior oblique and rectus capitis posterior major. What's important about this triangle is that this is where you can find the vertebral artery along the vertebral sulcus and the dorsal ramus of C1. And it's important to find this vertebral artery because this is the artery at risk. And if you're not careful, you use a monopolar, you can injure the artery and get into trouble early on. So I recommend do not use the monopolar as you're getting down to the deep layers of the muscle layer. It's important to use blunt dissection, and with scissors, use a microdoppler. But most importantly is the anatomical landmarks of the bone. It's very important to palpate and locate C1, and I typically will expose C1 in the midline, in the medial aspect, and then as you follow the bone, just follow it subperiosteally until you get to the vertebral sulcus here, which we also call the J groove. On a right-sided approach, this groove looks like the letter J, and of course, in a left-sided approach, it's a opposite looking J. But this groove helps you find the vertebral artery and avoid injury. So this is the dural incision behind the sigmoid sinus into the area of the cervical dura. How do you find the hypoglossal canal? The hypoglossal canal, I think, is a very important landmark. So as we drill the bone, as I said, we follow the dural tube and you look for the bone that's in this corner here. This is the jugular tubercle. And as you're drilling the jugular tubercle, you will often see a venous channel here, which is the extradural hypoglossal canal. And to me, this is the limits and a good landmark of knowing when to stop drilling. I generally do not drill into the infrahypoglossal region because this is the occipital condyle that articulates with the C1 lateral mass. And if you disrupt this, you have a higher chance of craniocervical instability. And this really does not buy you that much access. What's really helpful is focus the drilling right here in this corner, because this is what's going to obstruct your line of sight as you're looking anterior to the foramen magnum. We open the dura and we'll have a beautiful view of all the lower cranial nerves. And it's important to know that the advantage of this approach is really looking from inferior to superior, as most of these pathologies are actually below the lower cranial nerves and below the jugular foramen. So here's an anatomical dissection we did in the lab. You can see here's the vertebral artery right in that J groove. This is the J groove. And look for the articulation of the occiput to the C1 lateral mass. This is the joint that we must preserve. Here again is the joint of the occiput to C1. We don't expose this in surgery, but anatomically you should know where this is and you can palpate it. And so when you do the initial craniectomy, expose the foramen magnum, and then I'm showing you the opening of the dura without drilling of the jugular tubercle. Look at the obstruction that you see here. These are the lower cranial nerves. These are the 12 rootlets, and this is pica. And again, these are the 12 rootlets that you see down here. And if we drill off that jugular tubercle, expose the hypoglossal dural canal. Here is the hypoglossal canal. The jugular tubercle has been removed. You could see that your ability to see ventral to the foramen magnum is much better and has created a nice corridor. So let's look at some case examples. This is a foramen magnum meningioma. Look how it's encasing the ipsilateral, the right vertebral artery in a 270-degree fashion. We've done our suboccipital craniectomy and C1 hemilaminectomy. And what we're doing now is we're going to drill off the occipital condyle, and here's the jugular tubercle. We're aiming for that upper corner of that bone, so we remove that obstruction of the line of sight. Remember to excise the occipital atlanto-occipital ligament to better expose the dura. And we do not need to transpose the vertebral artery. It's rarely required for vast majority of these approaches. The only time I've really had to transpose the artery is if I'm accessing a chordoma that's occupying the C1, C2 joint, where we need to move the vertebral artery. But now we're opening up the dura. It's just a curvilinear incision. And we're working here really well below the lower cranial nerves. There's the tumor. There's the spinal accessory artery. And this is the vertebral artery that's being partially encased by the tumor. And there's the spinal cord. This is a right-sided approach. It's often difficult working in these tight corridors, but some maneuvers that can help you. You can divide the nerve rootlets of C1 or even C2, and then it's important to preserve the spinal accessory nerve. And you can mobilize this spinal accessory nerve either anteriorly or posteriorly, depending on where the tumor position is. So in this case, the nerve is naturally anterior, and I'm working behind the 11th nerve. And then we have a small corridor where we can start debulking the tumor. And we're working using a sonoped here, working behind the nerve. And again, very important to know where the vertebral artery is. And debulking is very important because this is what allows you to collapse the tumor and create more space to work around the tumor and the critical structures. So there's the 12th nerve. And here we're going to work between, this is the hypoglossal triangle. These are two rootlets off of 12. There's usually a set of upper rootlets and a set of lower rootlets, and they both will meet at the proximal hypoglossal canal. And it's very important to preserve the arachnoid that's on top of the spinal cord. There's usually a thin layer of arachnoid, and you could peel it off of the capsule of the tumor. That arachnoid layer is very important because sometimes the anterior spinal artery will be invested in that arachnoid. So if you mobilize the arachnoid towards the spinal cord, you're less likely to injure that. That can result in a very serious quadriparesis, very bad complication, especially for the tumors that are adherent. I will show you a different case where we use that technique. But these tumors, you're working in these small corridors. You're working behind the vertebral artery, in front of the vertebral artery. So yeah, it's important to work in a piecemeal fashion, debulk the tumor sequentially using sharp dissection, and then using an ultrasound for debulking. So this one was very difficult because of all the partial encasement of the vertebral artery. So here we've mobilized the vertebral artery anterior so we can have more access behind it. And now we're working in front of the vertebral artery using this side cutting aspirator, being very careful to not injure the cranial nerves. And very important to monitor the cranial nerves. We use lower cranial nerve monitoring. And this is the final view. This is the attachment of the tumor. This is the ventral clival attachment. And these are the two vertebral arteries after the final removal. And this is the tumor here, and these are the lower cranial nerves here. So the approach is looking from down to up. And many people who do endoscopic surgery have said, well, the nerves are in your way when you're doing this approach, so it's better to do an endonasal approach for foramen magnum meningiomas. And I generally disagree with that. I think if you understand this approach, you will realize that you're working below the lower cranial nerves. You're working from down to up, having that down to upward view. This is a technique I like to use. Use a little fat graft over our suture line and then use a plate to hold pressure on the fat to prevent pseudomeningocele. And this is a useful technique, I believe. So here's the post-op scan, a complete removal. This is another example. This is one that totally encases the vertebral artery. And these are much more challenging, higher risk, because the artery is totally encased. Here we used a virtual surgical theater to help us visualize where this vertebral artery will run through the tumor. You can see here, this gives you a visualization where the artery will be. And I think this is helpful for some preoperative planning to do this virtual fly-through to help us understand the critical anatomy and to avoid any injury. So here's the opening. We're working below the cerebellum. This is a right-sided approach. And you can find the vertebral artery where it enters the dura. That's the proximal control. You can also have proximal control of the extracranial vert. In case you have an injury, you have proximal control. You have to be ready to trap it and then possibly repair it if you have to. But here's the dissection initially of the ventral foramen magnum. And then it's important to devascularize the tumor early. So if you can get to the anterior foramen magnum, you can begin to devascularize. And as you devascularize the tumor, it actually becomes softer throughout the case. And here we're removing the tumor in a piecemeal fashion. I try not to use too much cautery, especially working around the nerves. So we tend to, work around the bleeding. But you want to be very judicious on using cautery. So here's the final view. You could see this is the vertebral artery and the pica that came into view. I often will use an endoscope to look around to make sure there's no residual tumor. This is the dural attachment that's been cauterized. And I generally don't strip the dura. It creates a lot of bleeding. So we usually aim for a Simpson grade 2 resection. And I showed this cervical spine CT. I do this routinely to ensure that I did not violate the OC1 joint. And it's good for teaching purposes to really assess how lateral did you drill the foramen magnum. And then here's the post-op scan as well. Another case example, this one has a 270-degree vertebral encasement. We're coming from the left side. Here we're drilling that corner of the jugular tubercle. It's really the corner of the foramen magnum, and you really want to drill that down to avoid any obstruction of line of sight. Here's an example where the spinal accessory nerve is now draped posteriorly instead of the previous case. So now we can work in front of the 11th nerve. I showed you the dentate ligament. It's important to identify the dentate ligament and divide that early, because you'll untether the spinal cord and you'll be able to work around it and not injure the spinal cord. So this video, I wanted to show you how we can undress the tumor. See how the tumor has a thin arachnoid layer? I'm stripping the arachnoid off of the tumor capsule so it goes towards the side of the spinal cord. Because this tumor was really adherent to that arachnoid. If you're working on the wrong side of the arachnoid, you're going to end up subpial on the spinal cord, and you can injure the spinal cord, injure the anterior spinal artery. So again, it's important to undress the arachnoid off of the tumor when you're doing meningioma surgery. We're going to identify the vertebral artery early on here. Here's the 12th nerve using a monopolar probe. And then here, because we've undressed the arachnoid, we can lift it off of the spinal cord. We're going to detach it from the dural attachment, being careful to identify where the vertebral artery is, and do further debulking. Here's the vertebral artery. You're going to see it coming into view. It's right here. So we're working in front of it, using some sharp dissection and hooks. And then here's the VA coming into view. And so once the tumor is adequately debulked enough, you can see by the end of the surgery, the tumor has now become very soft because now it's detached and devascularized. And then we can deliver and remove the remainder of this from the cavity. And here's the final view. Here's the vert. Here's the 12th nerve. Again, we're working below the jugular foramen. This is a down to up working view. Here is the lower cranial nerves. And then we'll use an endoscope again to inspect and visualize the beautiful anatomy. Here's the ventral spinal cord that was displaced. And that's the final view of the vert. So here's a nice complete removal. She was myelopathic severely and regained her ability motor function-wise. So here are some other examples of foramen magnum meningiomas, a lot of different variations. This is a different kind of tumor. This is a solitary fibrous tumor, previously known as a hemangiopericytoma. This was incredibly difficult, very, very firm and very stiff. And this is an interesting case. This is a cystic schwannoma, but this was arising from the hypoglossal nerve. Notice how it was going into the hypoglossal canal. She had severe myelopathy, and the far lateral approach was a great approach here. I left some tumor in the hypoglossal canal. I tried to debulk it, but we treated the rest of this with radiosurgery and had a great result. The rest of the tumor essentially disappeared. This is an epidermoid tumor that was going down to the foramen magnum. So this was combined with a retrosigmoid approach, but look how the tumor is well below the foramen magnum. A retrosigmoid would be inadequate to reach down here. So the far lateral approach here gave us great access to the lower foramen magnum and upper cervical junction. And here's the final view showing a nice tumor removal. We have done bilateral. This was a staged bilateral for this bilateral neuroenteric cyst. These neuroenteric cysts are developed from respiratory epithelium and filled with mucoid material. It's the same pathology as a colloid cyst and a Rathke's cleft cyst. It's the same pathology of a columnar cuboidal epithelium filled with goblet cells and mucoid material. And so we did this staged. You have to do it staged because you want to make sure after one approach, there's no lower cranial nerve dysfunction. Because if you have lower cranial nerve dysfunction, you generally don't want to do the opposite side because bilateral vocal cord paralysis can be quite debilitating. So she's done quite well. I show you this case. This is an interesting case. This is a dural AV fistula. This is a Cognard 4, Borden type 3. This is not feeding from the vertebral artery. This is do not mistaken the arterial feeder from the vertebral artery. It's actually coming from the vascular cuff where the artery enters the subarachnoid space. And so you could see at surgery, this is the right far lateral approach. This is the vertebral artery coming in here. And then there's a vascular feeders right coursing along the C1 nerve root. And we just simply clip that. And you can see the fistula disappears. It's a very simple surgery as long as you understand the anatomy of these dural fistulas, and you can get a great result. You have to treat these because these are high risk of spontaneous hemorrhage. These are high grade retrograde flow. And so that's your workhorse for the far lateral. And as I conclude this, I'm going to show you how we do the anterolateral variant. The anterolateral variant is to me a natural extension of the far lateral, except you include a mastoidectomy and a cervical neck exposure. And the positioning is different. Instead of a dorsolateral park bench position, we use this approach for jugular foramen tumors like paragangliomas, but the approach is different. It's supine with the head turn because you want to get into the anterior neck. And what we'll do is an infralabyrinthine mastoidectomy and connect it with a cervical neck exposure, which gives you this great access of the entire jugular venous system because you need control to ligate the internal jugular vein and open up the sigmoid sinus so that you can isolate the tumors that are inside the jugular bulb, and you get this panoramic exposure, and you can work in these different zones of approach and tailor your zones based on where the pathology is going to be located. So here's an example. This was a patient with complete 9 through 12 lower cranial nerve palsies. This is a winged scapula because this is from 11th nerve palsy. Look how the right shoulder is lower than the left, and a right hemi-tongue atrophy. This is a chordoma, a very large one in the parapharyngeal space, compressing the brainstem and also eroding the lower clivus and occipital C1 joint. So we'll do this through a supine C-shaped incision. This is the facial nerve, the fallopian canal. This is the sigmoid sinus. And this is the tumor that's eroded the entire occipital condyle. The whole joint is disrupted. This is the vertebral artery. This is the V3 segment in the vertebral transversarium. And we're isolating the fallopian canal. This is the fallopian bridge technique where you leave the nerve in the bone so you prevent any facial palsy, but you can work around the mastoid segment of that nerve. Here we're occluding the sigmoid sinus endoluminally, proximally, and then injecting Surgiflow distally to prevent the back bleeding from the inferior petrosal sinus. And this is the tumor inside the jugular bulb that we removed because we've isolated the jugular system. And then we now go for the tumor that's in the parapharyngeal space. This is the tumor that's inside the neck, working in front and behind the carotid arteries. And then we'll excise the rest of the jugular vein up to the jugular foramen and then drill off the remainder of that occipital condyle. That condyle is largely loose and compromised. And then this is the rest of the tumor in the craniovertebral junction. This is the lower clivus we're drilling off. And that's the bottom right here of that clivus that you see. And then this is the tip of the odontoid. I did not have to transpose the vertebral artery in this case, although I prepared to, but it looked like this tumor created a huge corridor, so I didn't have to do any of those maneuvers. And then this is the intradural component of the tumor where it extends intradurally. This is the ipsilateral vertebral artery. And then these are the lower cranial nerves, which are completely dysfunctional. So we'll divide these when the patient has complete pre-existing palsies. And then this is the last view. This is the vertebral basilar junction. Large dural defect, very high risk of CSF leak and pseudomeningocele. So we pack this off, close off the middle ear with bone wax, and then use a fat graft with our dural closure, and then the MedPore plate. So here's the final view. I think it was an excellent result. And because of his existing lower cranial nerve palsies, he had to have a peg and a trach, and we brought him back for a second stage fusion. This is a paraganglioma. This is a highly vascular lesion located in the jugular bulb. This is the same approach. This time we've closed off the external ear canal to get into the middle ear. And then I'll just show you the approach. We've opened up the jugular system. This is the fallopian canal. This is the left side. This is the tumor in the jugular bulb. And then you can see the coils here from the preoperative embolization. Use Surgicel if there's bleeding from the inferior petrosal sinus. And then now we're going to open up the, this is a muscle called the rectus capitis lateralis. This allows you to communicate the jugular vein to the jugular bulb. And what we're going to do is we're going to open up the top of the jugular vein. And then we'll tie off this is the jugular vein in the neck. And we're going to open up the lumen inside the jugular vein. And what you'll see here is the tumor. This is the tumor that's in the jugular vein going up towards the jugular bulb. Fortunately, this had a nice smooth capsule to it, and we could remove the remainder of this paraganglioma. You can see it's largely devascularized now, and get this nice removal. And here's the final view. So in conclusion, this far lateral approach and all the variations I think are useful for craniovertebral junction lesions, but we have to tailor our approach to the pathology and try to preserve the stability unless it's already destroyed by the pathology itself. Thank you again for your attention.
Thank you, Dr. Liu,
for the nice presentation for so many cases. Sir, you have a lot of questions, but if you don't mind, we will switch to our next speaker, and we can answer questions after our two speakers. So, Dr. Mario, if you have any comments?
No comments. I think great cases, particularly the last paragangliomas, was certainly, very scary. So congratulations on the presentation and the technique. Shall we go with the next speaker, Nargisa?
Yes, we can go with the next speaker, and after all speakers, we can start questions and answers.
So happy for me to introduce Professor Spallone. Yeah.
Yes, sir.
Aldo Spallone been one of the pillars of the Italian Neurosurgical Society, a very skilled surgeon with an expertise in skull base and neuro-oncology, and he completes his surgical practice with a very rich interest in spinal conditions as well. Has always had very strong ties with Russia. Currently, he works in Moscow, and he will be presenting his life experience in the field of skull-base surgery, including some initiative that touch upon global neurosurgery. So, without further ado, Professor Spallone, are you ready to share your presentation?
I am. Actually, I want to double
share
check.
your screen.
You listen to me? Do you? Can you hear me?
Yes, we can
Yes,
hear
we can
you
hear
loud
you.
and clear.
Can you even see me?
And we can see you as well.
Okay. First of all, I want to say my best thinking and giving the best thinking feeling to Mario Ganau. I didn't know him before this occasion, but I feel that it's quite, his experience is quite similar to mine. Since he's, as far as I understood, it's a very world-oriented educator. I was surprised to know the fact that he did a PhD in Rostov-na-Donu. Let me say a couple words in Russian to my Russian colleague, since I am more speak Russian now than English. Товарищи, действительно великий человек, который проводил какое-то время в России, когда это было не совсем модно. И то, что он делает для вас и для нас, потому что я тоже являюсь русским сейчас, это действительно очень важно в этом трудном моменте. From now on, I will honor the audience and speak in English. And I would say, first of all, that I express my deepest admiration to Professor Bennett for his wide view of the educational needs of medicine, neurosurgery in particular, I would be very happy to be in contact with him. I spent some time in Miami since I own an apartment there, but strange to say, I don't hold anymore an American visa. So the apartment is there, but I'm not there. But if I will be the good luck to be back in the US, I will be very happy to meet him in person. And also, I have to express my deepest admiration for Professor Liu's work. It's really outstanding. As far as myself, I present here as a not very young man, as you can see. What can I withdraw from my long time experience on traditional concept of skull-based surgery? I understand that there are several new tricks, and mostly the introduction of endoscopy change the profile of our specialty. This is very important. This is very welcome. Even the use of parasurgical effective means like precise radiosurgery and targeted therapy change this view. But as somebody who was here already explained and showed, having some idea of properly using traditional skill tricks of skull-based surgery can be important. So this makes and gives maybe some sense to my speech. I wanna start first with this very brief look at that. I'm the president of Italian Association of Italian Scientists Working in Russia. This is simply the logo of our seminar, simply to remind my Russian colleague and not only to them that this is not an easy moment. But science is science. And initiatives like this are very, very welcome and must be appreciated and appraised, since once again, science is science. Any discrimination should be strongly avoided. This is what our Association of Italians Working Russian is trying to do now. And this is only the first of several seminars. And here is just a reminder of how the skull base is made. I don't think that this is of any importance for the audience. Simply remind that the holes where nerves and vessels coming in and out are very close to each other. Something to just remind that what can look conceptually as a big distance is not. And the idea of a skull-based surgery is actually to shorten and the distance and simplifies the work of a surgeon in a deep part of the brain of the skull. And as it is, the skull, the base of the skull is very complicated, and it's it gives space also to an important, difficult to deal with structure called the cavernous sinus. Now there are other means to deal with it, but once again, the complicated anatomy is quite known to everybody. And this is a view which reminds you that there are many, very structures which are difficult to reach if you don't deal with the base of the skull, which is the idea of our specialty. Some reminder of the relationship between skull, base bone, and the vascular tree of the brain, and position of the important nerve, the facial nerve, maybe the leading nerve of between the cranial nerves. And some anatomical views. You see an intraoperative picture showing the trigeminal nerve, the facial vestibular complex, and their relationship to the upper part of the basilar artery, and some anatomical sketch of the craniovertebral junction. And now I'm going to the basic traditional approach. The first one is the transfrontal approach. You see the logics. If you go flat just above the orbit, you can reach the clivus. This was the concept of Professor Guyot, first started and popularized this kind of approach. And this is what you can do. If you go either extradural, it's a little more difficult, or intradural. If you go intradural, you can expose easily both optic nerves, the chiasm. You can see the anterior vascular tree very easily. You can respect also, if you are careful, the olfactory nerves, but you would have problems with the reconstruction if you have to deal with intradural tumors. And this is the way to deal with. You prepare, and this is a trick which everybody knows, a large flap of pericranium. You can rotate inside. It can close the communication between the sinus, which sometimes can be open, and the intradural content, to decrease the risk of CSF leak and consequent infections. We already spoke about that. But there is a further trick which I used, and I learned this when I worked in New York with Alan Kantrovitz. Maybe John Bennett knows him. He practices in Miami now. Just to leave a little piece of bone, as you can see here, attached to the pericranium when you do your bifrontal craniotomy, and then you shift him down to close the risky portion of your basal dissection. It helps healing the bony defect much more efficiently, since the piece of bone is vascularized. The supraorbital approach it was already very well exposed by Professor Zrayev. So I will go on just to speak of a false approach. And I show here a paper which was published in a leading journal, just showing a technical modification which allowed to achieve this. This is the patient. This is the front orbital zygomatic craniotomy, and this is the piece. You see from here that the advantage to have one piece bone to be replaced very easily in a difficult economical condition. You don't even need plates. It's enough to put 2 silk sutures and it heals perfectly. And this is what you can do if you do this approach. You are exposing very well this angle, and the anterior clinoid can hinder something. You can go ahead with the clinoidectomy. Just to remind you how to do it if the movie starts. The movie doesn't want to start. That's a pity. So the idea is that if you hollow in like it was a tumor with the careful use of the diamond drill, you can rotate easily at the end and remove the final part of the clinoid between the extradural ICA and extradural optic nerve. And you see in it's a pity that the film doesn't show it now. You can see at the end by this little rotation maneuver how easy and risk-free is this in order to expose the third nerve at the end. This is actually a sketch of what you obtain with it, a full view of the optic nerve and a full view of the carotid artery towards the cavernous sinus. And this is an operative sketch of an approach like this. You can see here the third nerve, the elongated towards the cavernous sinus ICA, the elongated optic nerve, the anterior cerebral, and this is a good view to basilar artery here and the upper part of the brainstem. This case actually, which I would be trying to show you later, is a giant aneurysm, top basilar aneurysm, which really benefited from this approach. And middle skull base approach are quite easy and popular. This is the basic sketch. You see here the trigeminal roots, which are leading the extradural dissection of the dura in order to have a full view on the base of the skull. The extension of this concept is actually the pre-sigmoid approach. It can be an anterior with removal of the anterior portion of the petrous bone. Is a more popular pre-sigmoid approach, which is here schematized. See incision below the ear with a lateral view. I like to have the mastoid pretty up. I rotate the patient a little bit down. This is the same concept that Professor Liu has exposed in an outstanding picture. This is the concept of the craniotomy, a small temporal craniotomy, as bigger retrosigmoid. And what is very important, you can use the craniotomy here, never do it here, because there is no way to save and to avoid injuring the jugular bulb. I learned this from Vinko Dolens. If everybody of you saw every time operating Vinko, it was the best hands-wise neurosurgeon I ever saw, but it was too much self-secure. In America, he did a demonstration. He passed the cranial here and opened completely the jugular bulb. It was so good to repair it, and I learned this. It was a good lecture for me because I had to do it. One case in my hands, and I was able, thank God, to manage it. Thank to him. But the patient lost lots of blood, and finally, thank God, he was well. The idea is that when you do this opening, you are faced by the free edge of the tentorium that you have to cut to the end after having closed the petrous, the superior petrous sinus to the end, to have at the end the full view of the fourth nerve, which guides you to the brainstem. An extension is a transpetrosal transtentorial approach, which is obviously more aggressive, more wider, bigger risk of loss of hearing that you can avoid by respecting anatomy if you do a pre-sigmoid approach. This is the schematic view from a Japanese paper, and this is the idea of removing the portion necessary removal of the petrous bone, that you have to have full access to the lower area of the brainstem, including some part of the craniovertebral junction. This is not a substitute. It has different indication from the approach that Professor Liu has outstandingly shown. It's just for lesion more between the lower, middle, and lower third of the scat, carpa in this case, of the clivus. And so it can benefit from the appropriate closure of the sigmoid synod with full respect of vena lava for obvious reasons, mostly on the dominant. And this is a schema which shows you what you can gain with this approach. Good view of the basilar artery, full view of the intracranial fissure, and good view, in this case, of an aneurysm. And this is an anatomical sketch. You see here lower nerves, the vestibular facial complex, the basilar artery, the vertebral basilar junction. So once again, to see that this approach can give you a lot, and as is indication in demanding cases. The translabyrinthine approach is a well-known approach, mostly used by ENT surgeons. It can give you this good view of a portion, extended portion of a facial nerve, plus a lateral view of the cerebral peritoneal angle with an unhindered view on the brainstem. You can proceed by doing the same dissection requested for pre-sigmoid by identifying, here you can identify in this cadaveric dissection, the hearing apparatus, how to remove the bone and show the two components of vestibular nerve. And an extension of this is actually the transcochlear approach, which requires obviously removal of the hearing apparatus, and is indicated when the hearing function is lost. The major problem, this is another approach which is pretty much below the ENT managing skull-base surgery. The real problem is facial weakness. Facial weakness due to the fact that removing the facial hair from the bone gives inevitably problems to the vascularity of the nerve. And the idea which exposed Professor Liu once again to leave some bone around, it's quite good to avoid or reduce the risk of this complication. That's anatomically the view that you can obtain with the full view of the lower part of the clivus. And this is anatomical sketch. You can see here basilar artery, well extended facial level which can displace whenever, and the jugular bulb. And the far lateral approach is something which was outstandingly exposed. I don't have to say anything beside two things. It can be, this is a crucial portion, just you have to be able to incise the dura, just posteriorly to the entrance of the vertebral artery. It can give you some more space to do a bony dissection if you displace downward the vertebral artery. Professor Liu said, and I believe him since he demonstrated to have a very large experience, that then can not be fully necessary. I was rather confident to do it regularly. Simply it gave me more confidence in removing the medial third of the occipital, occipital joint, to avoid the consequent instability. But that there is a point which should be maybe outlined. I liked to go from medial to lateral to the atlas tuberculum to know where the vertebral artery could be met. There was a leading English surgeon, Alan Crocard, who was doing the opposite. He was feeling with a finger the atlas tuberculum, going straight away there and doing the opposite dissection. This also works because the idea is to expose this area. And finally, the idea is actually to have this kind of view, and I don't have to go further, and to have this kind of view. This is the displaced vertebral artery. This is a retractor put in holding the muscles in the way to give this area free for intradural exploration, dissection. And according to this, I want to add two things, which I learned from my teachers, Professor Guidetti in Rome. We wrote a leading paper on the subject very long ago, and Professor Konovalov in Moscow. Both they told me, the biggest is the tumor. The easiest is to remove. If you do a wise intratumoral hollowing, is the easiest will be to remove it without having to do a particularly difficult approach. I don't know what to say about that. I respected their big experience. I was simply feeling more confident to extend a little more the dissection by removing part of the skull base, as some of my colleagues already had said. Transsphenoidal and transoral approach are skull-based approaches, very well known. They have both the limitation that they can visualize, they can help you to visualize lesion no more than 1.5 centimeters from the midline, and this is not the rule. Usually tumors are bigger. And we have also some beloved ENT surgeons approach, and Professor Liu demonstrated us this kind of approach outstandingly. This is the anatomical view. It's extremely complicated. You can see here that if you do a nice dissection, remove the ear, you can expose very well the lower cranial, the carotid artery, the vertebral artery, the basilar artery. But once again, I think that the indications are quite limited. Thank God. This approach is really, really difficult. A demonstration how can be used one of these difficult approach, but I am afraid, unfortunately, with no sense. I had a case of a giant vertebral aneurysm, which I approached by using an extended the lateral skull-based approach by, let's say, an extension pre-sigmoid approach by removing fully the cochlear apparatus and cutting properly the transverse sinus. And this is what the view I had. Very beautiful, very well demonstrated basilar artery. You see no tumor here. The anatomy is the anatomy you see. Good view of the brainstem, lower cranial nerves. The aneurysm already dissected, but even some view of the cranial nerves and the branches coming off from the basilar itself, but no way to demonstrate the aneurysm. Was impossible to go on to the properly expose it. Maybe I could have considered to use the far lateral, maybe combining them, but finally I had to deal it with a very traditional way, simply by wrapping the aneurysm. Thank God, it didn't bleed any longer. These are some cases. A small anterior petrosal meningioma, that's the exposure. You see the tent cut, the tumor coming out, and the final result. A bigger tumor with a bigger approach, and you see here, and good results. A very big tumor, which was a redo case, and the tumor itself was not a good tumor. In heroes, it's have the clinoid, so he helped in a clinoidectomy. This is a movie. Hope once again the movie doesn't. Yeah. I had some problem with the connection today. I apologize. So, but it saved your time. And this is the final, apparently total removal. This is another tumor, clinoidal meningioma growing up. And this is once again, it doesn't work, but you can see here the very bad condition of the right optic nerve and the final total removal. And this is, it's a pity that it was a good movie, a giant basilar aneurysm. And the approach allows me to respect the perforator. This is what I showed you already. You see the intracavernous approach too. I will try to, once again, to do it, but no way. It doesn't want to work. And this is post-op control. And this is a very nice brainstem, let's say, epidermoid going down, which benefited from pre-sigmoid approach. I was able to show very well, to expose very well, even details and work around the facial nerve and the lower cranial nerve by removing step by step all the details and cutting probably the arachnoid. And the patient had some problem with lower cranial nerve function. She was intubated for 4 days, then he recovered completely. And this is the post-op control. This is another challenging case, before and after, using the anterior presigmoid. And this is something that maybe could be interest to people who has a love for adventure like Mario. Thank you very much, Mario, for allowing me to be on the spot between these very distinguished specialists, and maybe even idea for Professor Bennett, whom I see he has a tremendously high H index, 3 times higher than mine. I congratulate you. Then mostly he has a very big love and wish to help young neurosurgery by sharing knowledge and experience around the world. Thank you once again to everybody who does not discriminate Russia in this difficult moment. This is what I did in Cuba, another, let's say, strange country for Americans. This is how I started. Occasionally, I made a trip to Cuba and was invited to give a lecture by making some demonstration in cadavers. Then we started to think on an agreement. This agreement was actually a very serious agreement between my university at that time and the Italian and Cuban governments. He had some kind of international recognition, but the funding was very little. You can see here, we worked with just pocket money, let's say this way. And this is actually the documental base in Spanish. And this is serious. This is an official document between the Ministry of Foreign Affairs of the Republics of Italy and Cuba, stating that it was an official agreement. And that's the same in Cuba. And this was one case that I did in Cuba. This was before. I can see here is very crude cases. This was very demanding chordoma. And this is after you see the removal, the anterior part of the petrous tip, with which I was able to fight and remove completely this tumor opening the dura. Then I close it using a fat graft. This is actually my necessary homage to Professor Figueredo, the leading neurosurgeon, the leading neurosurgeon of Cuba at that time, who was not jealous at all. He helped me a lot, and thanks to him, it was possible to spread the program, the program wherever, because once again, very important, if you go to somebody else's country, is to be accepted. And I stop my comment here. This was the University Hospital La Habana. This was my group at that time. I'm a little bit different now. And all these people had some big experience abroad, here in Brazil, here in Spain, here in South Africa. She stayed in Cuba as a leading plastic surgeon, making some good money. And I'm here. So I'm here still a citizen of the world. And this is one case. This is actually a very rare case of intracavernous hemangioma. Before.
Professor Spallone, if you don't mind, we are a bit limited in time because we have
yes,
after
but I'm almost finished.
Chinese Grand
I'm
Council.
speaking about how
Thank
to
you.
educate a third world country. Maybe you could be interested. And this is after. This is an intracavernous adenoma. This is before and after. And this is, well, so reasonable good casuistic with some good results. And the idea is that, once again, if you go to somebody else's house, you must be accepted. you must agree very well with the house owners what to do, why to do it, and how to do it. Mario, thank you very much. Once again, thank you very much to all the non-Russians for the support to Russia, which I give regularly every day. And I tell you, it's not easy, but must be done. And I'm speaking about Russian science. Thank you very much for your attention.
Thank you
Thank
very much for
Thank you, Professor.
perfect presentation. Thank you.
I
We
think
would
the
like-
message.
Yeah, let me just say
Nargisa,
something.
1 second.
Go ahead.
Nargisa, 1 second.
Go
The
ahead.
message about the importance of uniting countries science is you know, something we cannot just sleep like this. Is extremely important. Should be our mandate day by day. And I congratulate Professor Spallone for his example. Thank you so very much.
Thank you, Mario.
Yeah, we'll be in touch because we do televise from Cuba. So we'd be very interested.
John, I can help you concretely if your country will give me once again a visa, since I own an apartment in the US, but I cannot go because I don't have a visa. Maybe you can invite me.
Oh, okay. Well, we'll talk later.
I can invite you in Russia. Don't worry.
Okay, we'll meet in Cuba.
Okay.
Okay. Okay, Nargisa.
Yes, thank you. If anyone has questions, please put them to the box, and we will move to our last speaker for today, Professor Kazadi Kalungu. I'm very glad that I know this person personally. Full professor and head of the Department of Neurosurgery, University of Zimbabwe College of Health and Science, honorary president of Continental Association of African Neurosurgical Societies, member of Royal Medical Academy of Belgium and Zimbabwe. So today, Professor will be talking about approaches to the anterior fossa lesions, including supraorbital approaches. Sir, the stage is yours. Thank you.
Thank you very much. Can you hear me?
Yes, we can hear you and we can see you. You can share your screen.
I'm trying to connect. If you can give me the way to connect. Can you see my slide? Not really.
Not yet. You see the share? How you doing, Dr. Kazadi? Can you see the share screen icon at the bottom of the screen? Share screen, it says.
Yes, yes.
Click on that.
No, I don't see it. No, I don't see it.
You don't see it. Do you have? I wonder if you need to update your version of Zoom. Nothing. Okay, you can't. Obviously, if you don't have that option, you can't do it.
Yes.
I think you may need. Yeah, can we go to the next speaker, Nargisa, and then we'll come back with Dr. Kazadi. In the meanwhile, we'll figure it.
We are done with speakers, so maybe we can, for now, do some comments and discussion. So then, once Professor Kazadi will.
I have a few comments for Professor Liu.
Yes, sir.
If you're still around. Professor Liu.
Yes.
Are you well now? It's 6 o'clock in the morning. You're not tired, no?
No.
Very
Wide
well.
awake.
Very well. Once again, I made you a lot of compliments when I was speaking, and they were really real compliments. So if you know the literature, you know that a leading paper was produced by Professor Guidetti and Mai on the subject. So I was always very, very concentrated on the subject you mentioned. So I must say that I really appreciate some of your tricks. The use of the Medport plate, for example, to put in place and leave in place the fat transplant is very tricky. I had a case when this piece of fat was too big and it get into the brainstem, caused a compression, and obliged me to redo surgery on that patient. But your trick is excellent. I would need maybe because of my experience to suggest you, sorry, this little further trick. Put a big seed stitch, stick it to the Medport plate, and you avoid not only the risk of pseudomeningocele, but even the opposite risk, to have the the transplant migrate into the deep of the cavity due to the decrease of intracranial pressure, which is related to the regular routine use of a CSF removal stuff, in which is one of the obligatory way that every skull-based surgeon does. Also, I really appreciate that you use very seldom the ultrasonic aspirator, and mostly if the tumor is soft, you are very careful in using the regular sucker to do removal section. This is extremely important because the ultrasonic aspirator gives you a sense of security, which is very dangerous in some situations. Mostly if you deal with the regions where nerves and vessels are very close to the pathology. And also very good idea to be very careful with bilateral lesions. I learned from Professor Sami, from one of his experience, not good experience, that if you deal with, for example, with Nisi tumor, cholesteatoma, which is spread bilaterally, and you do it in one session, you very likely bumped on a very bad complication, which requires a tracheostomy for a while. And the idea is to do it in 2 steps and wait enough. It's extremely wise. Really, it's something which deserves that you have a very nice treatment, and you have what is most important, good hands and good brain in the same time. Because if you have good hands and not good brain, it's like you have good brain and good hands. The results will be not good. What I would actually asking you your opinion is that what I said in my presentation is that the lessons I heard from my teachers, both Professor Guidetti and Professor Konovalov, they both told me if the tumor is big, the tumor itself does your work of dissecting. And if you do a good debulking, maybe those difficult maneuvers in opening properly the skull are not necessary. I always liked to use at least the way I do the lateral approach. I like to transpose the vertebral artery, and then it leads me to do the condyle resection the way it avoids to have a postoperative stability. But what do you think about this comment? You really don't think that the big tumor itself will make easier your work as far as removal, or you think that an approach like you described is always necessary?
Yeah, thank you for your comments. A lot of good points, and thank you for the comments that you made. I do agree that the tumor, when it's large, largely creates the corridor for you. Lots of times it can displace the anatomy and give you a nice safe zone. Certainly, I think you have to tailor your approach to your pathology. I would say for most intradural lesions, I have not found that transposing the vertebral artery is needed. Usually for extradural chordoma that's involving the clivus and the dens, I think moving the vertebral artery gets the artery out of the way so you can resect the C1 lateral mass and the odontoid and the dens from an extradural perspective. But if needed, I think in judiciously in some cases you can mobilize the vertebral artery if needed for some intradural lesions. But I haven't found that I needed to in most cases. But it's an important maneuver to know how to do. So if you need to know how to do it, you can be comfortable in doing it. So it's nice to have all of these maneuvers in your armamentarium, and knowing when to use it, I think is the principle I like to teach to my residents.
Thank you. Thank you very much.
Dr. Jamil Reza, if you wanted to give some comment or question.
No, I have a brief question for Professor Liu. My question concerned patient with dural arterial fistula. What symptoms and scenes this patient did have?
Yeah, good question. The patient, let me just see if I can find that case. I didn't write down the history on the slide. I apologize. I don't. The patient did not have a hemorrhage. It was, I think it was found almost incidentally. I don't recall the patient having significant symptoms, but in some cases you can have myelopathy depending on the venous outflow and the pressure on the venous side of the dural fistula. Sometimes you can have ectatic compression. But when you see fistulas like this, I believe you must treat them because these are grade 3 Conyard, grade 3 Borden or grade 4 Conyard fistulas, and they have a high risk of spontaneous hemorrhage. And that's the natural history. They tend to have a aggressive natural history. But I think in this case, he was unruptured. And I don't recall him having significant symptoms.
Thank you.
Okay, Professor Kazadi, I see you already, so we can move.
Thank you. Thank you very much. I guess you can hear me very well.
Yes, we can hear you.
Thank you. Okay. Thank you, Dr. Satova, for the invitation and for organizing this wonderful meeting. Thank you very much. And I'm glad to see also my good friend, Dr. John Bennett. It's been a long time. We haven't seen each other. Once again, I should emphasize you are the pioneer of these webinars and courses, on Zoom teaching, and really congratulations for spearheading that, and thank you very much for your consistency. So I'm going to talk about the anterior fossa approach, and in fact, I will be putting a lot of emphasis on supraorbital approach. I know there is one of the speakers who covered it very well, and it was good to review the thing sometimes twice. And my talk will be shorter because it has been already covered, but it's good to see different experiences. Okay, so we've used it mostly on pituitary tumors and meningiomas. I know that other authors also, they've used it for aneurysms of the anterior circulation, but we do not have that experience, though technically it could be possible to be done. And pituitary tumors, we are talking mostly grade 3 and grade 4, not 6. Sorry, there is a mistake there. Is grade 3 and 4. And then, of course, meningiomas, as announced earlier on. For historical point of view, we should remember a few names which are very important. This is not something which was created yesterday. In 1900 years, Krauss first demonstrated the supraorbital and the subfrontal approach on cadavers. And he did the first resection of skull-based meningioma through this approach. In 1913, Frazier advocated also this supraorbital ridge resection to go to the pituitary gland and remove the tumors. In 1990, Pernesky and colleagues also popularized the keyhole concept on the technique, which we are using now today. But the real evolution started began with Fedor Krauses. It's very important to remember those names. More recently, we have Jane and Della Shaw, who described the supraorbital craniotomy, and other variants have been also proposed by Halmefti and his colleagues. I will talk to you a bit quickly our experience here in Zimbabwe and Africa. Until 1994, there were little data published on pituitary tumors, and the reason were, as you can guess, another lack of CT scans, and awareness of this pathology and the clinical signs and so on, and lack of technology and the instruments. And yet 21% of brain tumors were pituitary tumors, were coming very late, and we had macroadenoma, huge tumors. And this is a period which we did in 3 years only. We still have data, for other years, which we are going to compile and publish. This is the cases we saw, 37. The mean age was about 43, and there were more female than male. 83% patients were Black, because here in Zimbabwe we have a mixed population. So they were mostly Black. And the referring doctors, that's very interesting. They were mostly general practitioners, 46%. Why? Because those were my students. I taught neurosurgery and explained to them how to make a diagnosis. And those actually are the doctors who were referring those patients to me. And then ophthalmologists, of course, because patients were either almost blind or having impaired vision. And when they see an ophthalmologist, but when they see, unfortunately, the optician, they will change, glasses, and again and again, increasing, the power without knowing that, in fact, there is a pathology behind that. The symptoms are classical like everywhere else. Headache, blurred vision, people are feeling tired, decreased libido, though in our context, people do not talk about that. It's a bit taboo. So galactorrhea, secondary amenorrhea, depression. And when we talk the secondary amenorrhea, we are talking about a gynecologist. And sometimes ladies go to the gynecologist because they can't have babies. And since then, we've spoken also to gynecologists. And now they are sending us patients. They didn't used to do that because they didn't know what we were doing. I had to call them into theater to see what we were doing. So they got more confident. Now, the average rate quite long, 4 years, and the major clinical sign was visual impairment. About 85% of patients, they come with visual acuity, which has been compromised. And unfortunately, 8% of the patients, they come and they are already blind, okay? And you see there the commonest hormonal tests we do, because they are mostly available. And at that time, we didn't have really physician specialists in this pathology, so that they could do all the hormonal profile. But with those few hormonal profile, we could do quite a lot of things, including, of course, growth hormone. And you see most of the patients had prolactinomas, then those secreting tumors, and we had also cases of acromegaly. As you can see, the investigations, CT scan, the majority of our patients, 84% had MRI, sometimes CT scan and MRI. Debulking was done in about 23% of 67% of patients, and partial debulking in 37%. And I'll talk to you about that more. We had a very good outcome, no death, and rather improvement of the patients. Of course, patients who were blind didn't recover, and we had some morbidities, diabetes insipidus, which were corrected. Some patients didn't have any change on visual acuity, about 2%, CSF leak, hemorrhage in nostril. One patient had epilepsy, but we never had any infection. Now, within 15 months, we had actually a recurrence, particularly patients who had microadenoma with supracellular extension. The recurrence rate was 10%, which was very high. After 5 years, we had the recurrence rate of 18%. So definitely the conclusion was that in macroadenoma, our degree of removal of the tumor wasn't really adequate. So we had to find some other way to do that. This is just the stages of microadenoma. You know, all of us. The one which is really we consider most is grade 3 and grade 4. So the goals of anterior skull base surgery ideally is curative surgery. It requires removal of the tumor. That's very important, you know. And we have to reduce brain and nerve retraction, minimizing stress to optic chiasm and the frontal lobe. And of course, we have to make sure that we improve the vision of the patient. We need to preserve both, at least one olfactory nerve, if not both, okay? Because olfaction sparing is very important to prevent, of course, complications like CSF leak and so on. But we have to keep in mind that those goals must sometimes be modified to avoid causing harm. Okay, it's not because everybody's talking about minimally invasive or keyhole surgery and so on. That's not the case. The most important thing is what we stated here is should be a curative surgery where you remove the whole tumor. Okay, so there are other modalities, and we can approach the anterior fossa via other techniques, like the traditional craniotomy, pterional, bifrontal, transbasal, or orbitozygomatic. Keyhole is very important. It's good. It's very nice. I'll show you some pictures. It's beautiful. But you must do it, or what I'm telling you, particularly young colleagues, you need to afford it, and you need to be able to do it, have the appropriate instruments and do it. Otherwise, it's better to do the traditional way or the old way, at least save the patient, rather than trying absolutely to do something which is more sort of recognized and more popular. Okay. Then you had other technique, endoscopic transnasal approaches, endoscopic assisted transcranial approaches, radiosurgery, of course. This is applied particularly on patients who are grown up and they are old, they cannot stand, major surgeries. So sometimes we just do radiosurgery. This slide is exactly the same like the previous one. There's a bit of change because this one is talking about meningioma surgery. As we said again, is a curative, should be curative surgery, not at any cost. Sometimes it's good to leave a small tumor rather than go and injure a major structure like optic nerve or artery and so on. And it requires, symptom grade 1 result. That would be really the ideal, including, of course, the tumor removal, surrounding dura, and invaded bone. And when you talk about invaded bone, it means we have to think also about the reconstruction. So this summarizing basically what we do. This is a supraorbital opening of the skin. Okay, you see here the incision is stopping here so that we spare the supraorbital nerve. But when I do my surgery, I actually cross that. I think on the skin. Now the structures which are under the skin. When I get to those structures, then I change my opening. Then I come here and go around the nerve and come back here so that the nerve is preserved. I can push it there. So that's the technique I use. And then you gain more room. But nowadays, with the experience, with a small opening, you can see quite a lot. Otherwise, if you can't, you can do the usual, opening we were using before, which is very good. And you can have a good craniotomy and approach the anterior fossa. Now, the primary criticism of this minimally invasive approach is that there is more limited field of view. It's a matter of learning curve. And in fact, if you follow really this technique step by step, you can see a lot of things. You need, of course, a microscope, micro instruments. That's very important. And people are scared that there is a possibility of partial removal of lesion. Now, if the surgeon is not trained for that, you better use the old technique. There is nothing to be ashamed about. In fact, it shows, somebody who is very wise. Otherwise, you can remove big tumors via that route. So positioning the patient is very important. You see this patient is positioned. The head is actually in hyperextension. You see the line here, hyperextension, so that when you get on the base of the skull, the brain will actually fall on this area of the skull, so that you have room there, and plenty of room actually. This is very important. Now you see here, this is the skin incision. We also make here the area where we know that we have the supraorbital nerve, so we can go actually beyond that. We used to do that before to have more room. Now we can stop the incision here and also the incision there. Now, of note, we always shave patients here. People will say, why are you doing that? Until we say, what? We don't want to have any infection. Maybe I'm biased, but I don't like to keep, the head. We prefer to shave. Women, ladies, have no problem about that, because after all, they do it anyway from cosmetic point of view, and then they put a lot of makeup, so it works very well. So that's not a problem. For men, they don't also they don't care also as well, and because after that it will grow in anyway. So this is the setup now. This is what happening when we open the dura after we've done the craniotomy. You see the dura is initially, very tense. We open it, we see that the brain is also tense. And then what we have to do is just progressively drain the CSF slowly. And you'll see that this brain will actually fall on the back because this patient, it's very important to have this head on hyperextension. It's very important. And you see, you can reach the base of the skull and you can visualize already the tumor. So any tumor from right to left. I go mostly to the right side because I'm right-handed, and it is easier that way. You see the size of the craniotomy is very small, okay? And you can see here, it's about 5 centimeters, which is very small. And you see here, okay, we've opened supraorbital craniotomy. You see we've opened, then you can see the optic nerve here. This is the optic nerve. You can see the pituitary tumor there, and you can actually see also the optic nerve the other side, okay, which is very easy to reach, and you can remove the tumor very elegantly without any problem. This is after the operation. You see, so we did 35 patients with this standard supraorbital craniotomy, 12 meningiomas, 23 pituitary macroadenoma. And since we've been using this technique, you see the recurrence rate in patients is 1.3. You remember the rate we had before, which was very, very high. And because with this technique, we're able actually to remove completely all the tumor, and we got much better results. And here are some examples. You see here tumor with supracell extension. Before, we used to do them by transsphenoidal approach, but the removal of all the tumor wasn't complete. That's why we were having recurrences. And we didn't have the endoscope to go and check whether we left a small piece of tumor or not. So by doing the technique we are doing, it worked very well. Same thing for these patient before and after the operation. You see again this patient. This patient has got tuberculous cellular meningioma. This is a nice indication. But also olfactory groove meningiomas can be done also via that technique. The only thing which is very important is to control very well the bleeding, and we describe that in other talk and other publications by using hydrogen peroxide and of course QSA or ultrasound aspirator. So it is possible really to do very good surgery. You see this patient here, and that's the tumor. That's the tumor. It's very important to check this sign so that you don't confuse with adenoma. You see, after the operation, patient has done very well. So, in conclusion, in the endoscope era, there is still large space for microsurgery. It's very important to remember that. Sometimes you have to combine both. So there is no the only way to do things. One wants to be like sorry to put this allegation, like a military. Sometimes you use this weapon or that weapon, or maybe let's say the hunter, not military, because it's a bit sensitive, particularly these days. You have to have always, you are a hunter, always have plan A, plan B, plan C. Okay. There are many surgical options. Okay. So you need to consider tumor. Here I've shown you the tumor which are classical, but sometimes the tumors actually are expanding laterally. And in our setting, we see huge tumors. And with that approach, we are able really to remove quite a lot of tumors that way. So in that case, also, it's better to use the frontolateral approach if you don't have enough experience on the supraorbital approach. Frontolateral approach is good enough, okay, so that you consider bilateral exposure if necessary, okay. So those blind spots you can use by coronary and endoscope assisted approach if you have an endoscope, okay. And it's very important to preserve the vision, okay. You can do in some patients, if the tumor is going into the canal, for example, in some meningiomas, you can do the early optic canal unroofing, okay. So this is a simple and affordable technique. It allows large space for microsurgery. Yeah, as I mentioned before, we have many options, other options. We shouldn't stick to one option only. It's not the only technique. There are many techniques. Sometimes you have to combine both of them. So I thank you very much. Thank you.
Thank you very much, Professor Kazadi, for your wonderful presentation. I am every time impressed to listen to your lectures, also because it's not easy to work in limited sources and cover the high population. So thank you very much. If anyone has questions or comments, please ask. Dr. Takashi from Japan has joined us. Good afternoon.
Yeah, thank you. Thank you, Dr. Karadi, to the nice presentations. So as for keyhole surgery, we have less experience. So sometimes to cannot go deeper. So and cannot find anatomies, and craniotomy part is different. So it's very difficult to. So we are very anxious about the small craniotomy. So what do you think? So to is it possible to point out and manipulate optimally the small craniotomy? So we have less experience and less confident about it still. You have some experience to the point of small craniotomy, keyhole
Yes.
craniotomy.
Okay. Thank you very much for the comment. Thank you very much. It requires a lot of work on cadavers.
Cadavers.
Yeah, once you do that on cadavers, you'll see how simple it is. It's very nice. And the positioning of the head, those are the key things.
Position. Yeah.
Positioning of the head on hyperextension so that the brain will fall on the back when you drain the CSF. There are people who are also putting in some cases, for example, yes, I think I forgot to mention this. In olfactory groove meningiomas, for example, I like to use also a lumbar puncture so that I can drain CSF. Yes, that will allow the brain really to fall down, so you can see, and you empty the tumor, and progressively you go laterally, so that you go and remove progressively. You take your time and remove progressively.
Thank you. At the point. Yeah. Okay. Thank you.
Thank you. Thank you very much.
Thank you. Any other comments or questions from the audience?
Yes.
I think.
Yes.
Yes, sir. Yes, sir.
Professor Calango, I like very much your honest presentation, since you are mentioning, let's say, not extremely large experience in a very honest way. It's clear that behind you have a very careful studying of the argument, and actually your recommendations are quite, like to say, quite understandable and to be commended. Simply, in such a nice way as you expressed and described the issue, you didn't mention intracavernous adenomas. They are rare, and they pose some problems because, as you mentioned very honestly, we have another clue to deal with the demanding cases, which is radiosurgery. You would know maybe that the early generation of neurosurgeons were rather reluctant to accept the fact that radiosurgery can help, but actually it can. For example, to be very aggressive in intracavernous meningioma is a nonsense, because it was demonstrated that they recur. I have a limited experience, but this was my experience too. You can do a perfect job into the cavernous sinus, but there are even some cells which gives you back the tumor. So radiosurgery is a good, extremely good way to be used wisely. Intracavernous adenomas are a challenge on this way. I tried to recruit some slides, but I cannot add them here, about my experience, which actually was made in Cuba. Why in Cuba? Because Cuba has some kind of a situation which is similar to yours, so limited research recurs, which is bad, and which obliges the surgeons to be very, very hand-wise, good and proper. And in Cuba, I applied your same philosophy. I did surgery with traditional means. Endoscopy was available, but there were limited experience on use on this specific field, and the results were surprising, because by using a wise approach on the cavernous sinus, on adenomas, which are easy tumor to be removed, that's the most important. They are soft, they are removable, they are easy. The only way is to look them wherever, which is maybe difficult. It allows us to do, in a relatively limited experience, there were 16 cases, a rather good, let's say, satisfactory observation that recurrence were limited, which is your experience, and I congratulate with that. But maybe, as a future message, we should accept the fact that radiosurgery does exist. And sometimes demanding approaches and difficult operations can be substituted at easier approaches and less demanding suggestion plus wise use of complementary measures as a resurrection point. What do you think about that?
Thank you very much, Professor Spallone. Your comment is perfect. And in fact, in those patients who had recurrences, we told them to have radiosurgery or radiotherapy. Radiosurgery, let's say radiosurgery. Unfortunately, in our country, we don't have that. So they have to go down to South Africa to have it. And when you do that, it means only half the patient can afford to go there. Otherwise, it works very well. And I agree entirely with you, definitely. So, and to the young people, I should tell them to be very careful not to adventure themselves into the cavernous sinus to try to remove absolutely the tumor, because you will have a lot of complications. But there are also the pseudo-invasion of cavernous sinus, where in fact the tumor is actually pushing on the cavernous sinus without actually entering into the cavernous sinus. And while you are removing, you will see that it's coming gently towards the midline, and then you can remove it very well. That's very, very important. So I appreciate a lot your comment. And another thing I wanted to tell you is that we share something together, you and me. I knew you, and so let me talk to you in your language. Sono molto contento di conoscerlo visualmente. Conoscevo il nome, adesso ho anche il viso. E mi ha fatto molto piacere sentirle e ascoltare i suoi commenti. I just said that I'm happy to know him. I knew him by name, but I didn't put the face on the name. Now I put the face of the name, and I spoke in his native language, Italian.
Yeah. Thank you for your comment. Let me add something. And I saw from your comment much similarity about my experience in Cuba. And I must say that my Cuban mate, the guy who sub-leaded the group when I was in Cuba, moved to South Africa. There is a big cooperation now. He stayed in South Africa, not in a leading hospital, obviously. They put him some sideboards. He had a nice experience, but I would think, considering his background, it would have been much better if he could have been working with you. You could do, he was a real master surgeon, hands-wise, so very good hands-wise. Now he's back in Cuba. I don't know whether he's happy or not, but it's a pity that this program is not so active with your country. It would have been much better. You have the same, very easy, very similar background, and both could benefit from each other's experience.
Thank you very much. I will definitely get in touch. If kindly you could send me his
send me your direction somehow. I'll look you up. Yes.
Okay.
Thank you.
I will talk to Dr. Satova. She will make us. She will connect us.
She's
Yes,
very efficient. I don't know her. I simply know that his name is Nargisa, not Nargisa. One of my best friends who moved to Moscow. She's a leading model here. She does a different job, and she works with some Italian. So Nargisa is one of my best friends here in Moscow. No Nargisa, Nargisa.
Nargisa,
Yeah.
okay. Okay. Thank you very much.
Thank you.
Thank you very much for this webinar. Thank you to all speakers and professors. I think we had a really nice conversation today. And next week, we will host again one more skull base session with different speakers. So you're most welcome to join again, to leave your comments and questions. Whatever Gmail addresses or numbers I will have to share, I will definitely share. And thank you very much for this Sunday. Thank you for your time. I see Professor James Liu able to join at 5 a.m. Dr. Jamil Rizaev Professor Kazadi, Spallone, and Dr. Takashi from Japan. Thank you, all of you.
Yeah, I'd like to say a few words before we close, Nargiza. And this is going to be the format in the future, because we're going to try to get advertisers, basically, to take part in this, the medical industry, to help pay for these webcasts. And let me show you really quickly what we plan to do. Hold on there, maybe where am I going? Okay. We'll have the webcast like we did now, and then the advertiser will have the choice of showing his product after the webcast. Like, for example, on this one, the QR code will work for the advertiser. You put your smartphone over that QR code and you'll see what I mean. Okay, can you put your smartphone over that QR code? Okay, and that's
We'll
valuable.
try, but I hope I don't know it doesn't work.
It doesn't work? Okay, keep
I'll
trying.
tell you now. I'll tell you now.
Okay.
I'll tell you now.
At any rate, the person is taken to demos, appointments with the company. In other words, advertising has improved. So we hope to change the economic model.
John, sorry for interrupting you. In Russia, if you don't have a trick called VPN, this does not work. So please, if you can send me your mail, I'll try to look you up. My email is very easy. It's Aldo Spallone altogether at hotmail.com. Very easy, the easiest one.
I got it. I'll write to you.
Thank you very much. I'll wait for you to contact me. We'll solve it out how to popularize it in Russia, where people who does not have VPN cannot have access on those tricks, unfortunately.
Okay, I'll talk to you after. We're going to end this right now. So, thanks everyone for coming. And the next one is, Nargiza, when's the next webcast?
Next webcast will be 28th of April, which will be next Sunday, 12 p.m. Moscow time. We will host second skull-based session.
Thanks for putting it together, Nargiza. You did a great job.
Thank you, everyone.
Thank you.
Bye-bye.
And stick around. You can stick